All right. Welcome, everyone. We are preparing everything on the background to start. Hope you all doing well on this Friday. And it's a very big pleasure for me to be here hosting this webinar. Today we are joined by a few different speakers, and what we're going to do is begin with our acknowledgement of country. So thank you so much. And we appreciate that you all have taken some time to be here to hear about some incredible work happening in the HCV elimination space with a particular focus on mental health and AOD settings. My name is Fabi Porto. I am the project officer at INSHU. And we are very thrilled to acknowledge the traditional custodians of the land from which I am speaking today, the Arawak people from the Bundjalung Nation. And I also acknowledge their continuing connection to land, waters, and community. I pay my respects to the people, the cultures, and the elders, past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. To get us started, we'd love to hear from all of you who is in the room today. So I will circulate a quick intro poll. Bear with me one second. All right, so please go ahead and select your primary role when you're ready. Seems like we've got good representation across different sectors. I'll be launching the results in a bit. Chris Wallace, I can't see anything on my end. Let's see if I can help you with that. I'm sorry, Chris, I can't really put that on the chat, but you're welcome to pop in the chat box where you're dialing from or what's your profession. And what I will do is just share the results now. So you'll see the representation is heavily on nurses and medical practitioners, AOD workers coming through as well, some policy managers, researchers, and others. Thank you so much. That's great. And secondly, just another question for you all. We would just like to know, how familiar are you with using PDSA cycles? Seems like the majority is not familiar with these at all. That will be an interesting journey, learning from the experts. I will now close this poll, share the results so you can see. Most of you are unfamiliar, so don't feel under pressure if you haven't heard of PDSA cycles before. And this is why we are all here today. So that's really great. Very nice. So who is INSHU? Before we jump into the webinar, I just want to provide you all a bit of a background for those who are new to INSHU. And as a quick recap, for those of you who are less familiar, we have organised today's training. We stand for the International Network on Health and Hepatitis in Substance Users, which is a global network of people dedicated to improving the health of people who use drugs. Our work is categorized across three key pillars: education and training, knowledge exchange, and policy and advocacy. We run a suite of programs globally across these three areas. INSHU was founded in Switzerland and it's governed by a General Assembly and a board, and our secretariat is based in Australia. To all our partner organisations and endorsing collaborators, I would like to extend our sincere thanks to the General's endorsement of this community of practice. Thank you once again, Westmoreton Health, Hepatitis Queensland, AVIL, Quiva, Queen and Quinada, for your ongoing support. We look forward to continuing to work together. We also extend our heartfelt thanks to Queensland Government and AbbVie for its generous support as the sponsors of this event. By funding this initiative, they've helped create space for important conversations, shared learning, and collective action. Our sponsorship policy is listed up on the screen. I would also like to thank our steering committee for your invaluable guidance, insight, and support in shaping the community of practice, as well as the whole program, including the symposium. Your thoughtful contributions helped to ensure all the events have been grounded, purposeful, and truly responsive to the issues at hand. It's been a big pleasure and privilege to collaborate with such committed and generous group. Your wisdom and lived experience were central to creating a space that is both informed and impactful. So the program consists on the intervention toolkit, a in-person symposium, and these communities of practice. So this webinar is the last of this series, and it aims to facilitate a community of practice, providing a platform to discuss any ongoing challenges and share innovative solutions on hepatitis C service delivery. A bit of a background on how this community of practice was formed. A couple of years ago, INSHU, in collaboration with local partners, developed a hepatitis C intervention toolkit. This digital toolkit profiled a range of interventions demonstrated to enhance the HCV care cascade. Interventions including DBS testing, point of care testing, care navigation, peer support, etc. You can access all of these, and including the how-to guides, for free on our website, and they're accompanied by a range of best practice models of care, infographics, and films from around the globe. The toolkit was intended for a global audience. However, as we know, challenges for implementing interventions are not only going to be different from country to country and locations, but city to city and even services to services. So we wanted to provide an opportunity for people to come together locally to discuss barriers and enablers to intervention implementation. So subsequently, in collaboration with an incredible committee, we developed a one-day in-person training program to support people to develop and enhance their own models of care and build connections. So these particular symposium is what has led us to being here today. And I'm assuming that most of you who are present were also present at the symposium. And we have a highly multidisciplinary group from a range of different sectors, including healthcare providers, frontline workers, community members, programmers, policymakers, all working in the mental health and drug and alcohol settings. These are some of the delivery locations from where this program has been delivered. We began piloting in 2022 in the UK and Canada, followed by the US in 2023, Portugal in 2024, and we've launched in Australia this year. Since the inception of this program, we have delivered 20 symposia and 878 attendees have come together as per the breakdown on the screen. And I am now thrilled to introduce our presenters for the day. Firstly, Lisa Ball. Lisa is a clinical nurse in the alcohol and other drug services at Westmoreton Health, where she has worked for the past 3 years with a specialised focus on hepatitis C. She brings over 7 years of experience within Queensland Health, having worked across medical wards, mental health units, and in community settings. Lisa is a strong advocate for vulnerable and often marginalised populations, actively supporting harm minimisation strategies, promoting health equity, and working to reduce the stigma associated with substance use in hepatitis C. Grace Odonogui. She is a dedicated clinical nurse with over 2 years of experience in alcohol and other drug services at Westmoreton Health. Her work is developed along a strong focus on hepatitis C management, an area that she's deeply passionate about due to its critical connections with public health, stigma reduction, and health equity. A nursing career encompasses different clinical settings, including custodial environments, inpatient mental health units, forensic mental health services, and emergency departments within AODs. She's actively championed harm reduction strategies, works to dismantle stigma, and promotes inclusive, empowering practices that support individuals on their recovery journeys. She's committed in providing respectful, non-judgment care and strives to uphold these values in every facet of her clinical practice. And lastly, Kim Rayner. Kim has over 30 years' experience as a community nurse, nursing leader, and community services leader, with a focus on complex cross-sector programs of work targeted at homelessness, drug addiction, mental illness, and disability. Kim currently holds the position of Clinical Lead Innovation and Health Strategy and Nurse Practitioner at MICA Projects, and is a founding board member of MICA Projects Inclusive Health and Wellness Hub in South Brisbane. Both services are focused on responding to the health, housing, and social support needs of vulnerable and marginalised populations. Lastly, myself, Fabi Porto, Project Officer here at INSHU. So just a quick overview of today's session. We are coming now to the end of this introduction, followed by the first presentation that will be taken by Lisa Ball and Grace, where they will be sharing a bit of their experience, including key features through PDSA cycles on a case study, some of the key barriers and enablers, as well as some lessons learned during implementation. This will be followed by a Q&A session, and we also have Kim presenting on a similar approach, coming with her own case study, also going through PDSA cycles, barriers and enablers, lessons learned, and also followed by a Q&A. We have an opportunity for all of you to come together for a Q&A after both presentations. This will be going for 15 minutes, and we will be closing up at the very end with a 5-minute additional support resource sharing. So coming now to Lisa and Grace's presentation.
There we go.
You're
Hello,
welcome.
everyone.
You unmute.
Okay, this is our presentation, West Moreton AOD's nurse-led model of care. Next slide, please. Are we doing it? I thought Fabi was doing it. I don't know. I can't hear you, Fabi.
Sorry, I've unmuted myself.
Are we doing the slides?
I will be doing that.
Okay, awesome. Thank you.
West Moreton Health acknowledges the Jagara, Yagara, and Ugarapul peoples, traditional custodians of the land, and pays respects to elders past, present, and emerging.
Next slide, please. Okay, so we just wanted to give everyone a brief overview of what our AOD service is. So our AOD service is made up of addiction psychiatrists. Alongside them are clinical nurses. Their role is centred on case management of clients to moderate and complex needs. Within that, we also have a dedicated Hep C team. This team was originally just Grace and myself, but recently with the upcoming expansion, we've recruited 2 more nurses, Kate and Dawn. We're also very lucky to have an amazing allied health team that works alongside us. This includes occupational therapists, social workers, psychologists, and peer workers.
Ipswich AODs has also been lucky enough to have recently started a youth team, which works with young people aged 12 to 25. The aim is to provide early intervention and create a safe space for young people to engage with our service. We also have a DABIT team, which is brief intervention, and they're based at Ipswich Hospital. They work directly in the emergency department across the inpatient wards, providing brief intervention at those critical points where people first present with drug and alcohol related concerns.
Sorry, Grace and Lisa, would you mind just coming a bit closer to the mic? We can't hear you very
sorry.
well. Thank you so much. Yes.
You hear us now?
Yes, that's better.
Yep. Okay. Next slide, please, Fabi. We'd just like to touch a little bit on demographics. So West Moreton Health is one of Queensland's key regional health services. We service about 325,000 people in the area through Somerset, Scenic Rim, Lockyer Valley, and the Ipswich areas. This population is projected to grow to 636,000 people by 2046. The residents' population diversity is an important aspect of Westmoreland Health. So we have 7 correctional centres in our area. We've got the Park Centre for Mental Health. 5.2% of our population identify as Aboriginal or Torres Strait Islander. 19.6% were born outside of Australia, with 12.1% of those people speaking a language other than English at home.
Next slide. Yep, thank you. So this is what we've pretty much based our service on. So we've got our nurse-led model of care. So with the screening process, we have conversations with our clients when they come in to see if they have had Hep C before. If they haven't, we will do an antibody test on them. If they have had Hep C at some stage in their life, we'll go to doing the point of care test. While we're doing that, we usually have conversations with them. We give them education about Hep C and about our treatment options that we have. The doctors will then have a chat to them once we've got that positive point of care test. They will then be prescribing their medication for them. We will then give them a follow-up phone call afterwards to see if they have picked up their medication and if they have commenced it, but also organising for them to make an appointment to follow up for their SVR. But we also have conversations with them about safe injecting practices, where the needle exchange is, and just bringing awareness with Hep C prevention. Next slide, please.
Westmoreland Health has many community mental health services, inpatient mental health and rural hospitals within our region. As you can see, the names are there on the screen. Ipswich is the only AODS within the Westmoreland region. So it's been a long-term goal of Ipswich AODS to offer Hep C testing to our community mental health services, inpatient mental health units, and to our rural communities. The biggest barrier for our rural communities is distance and how far they need to travel to actually attend Ipswich AODS in person. So just as a brief overview, Laidley is 47 kilometres from Ipswich AODS, Boonah is 46 kilometres, Gatton is 55, and Esk is 67.
So like any long-term goals, it takes careful planning, engagement, and persistence to bring everything to life. Our first step has been trying to build awareness and provide education about Hep C to the community mental health, inpatient mental health units, and rural communities, focusing on how to have non-judgmental conversations with our clients about asking about their Hep C status. These conversations have already started with our dual diagnosis coordinator, Lorraine, on the mental health units. The need for this education was reinforced with conversations that we had at with mental health nurses at the Ipswich Hep C Symposium in June.
So currently all the Hep C testing is done in-house at Ipswich AODS. Our goal is to bring Hep C testing out into the communities by making it mobile. We're fortunate enough to have a rural nurse that works within AODS, which is Julie, and she's already begun those conversations about our Hep C service and has laid solid foundations in the rural communities, which will be invaluable as we spread our efforts.
We'll also provide in-services to staff on how to refer clients to our Hep C clinic. This training will cover the requirements of the shared care between AODS, mental health units, and rural clinics.
Our plan is to select a pilot location to begin implementing the mobile Hep C testing and care model. This enables us to listen carefully.
Good conversation.
Is there a way we can turn the microphone up?
I don't know.
Sorry, we'll have a look and see. Okay, hang on.
The microphone is on. It's just that Grace is a bit too far from the microphone. So we can hear Lisa quite well, but not as well, Grace. So just keep the mic in between. Thank you.
You want screen? There we go.
So our plan is to select a pilot location to begin implementing this mobile hepatitis testing care plan. This enables us to listen carefully to staff and client feedback, to adapt our approach as needed, and ensure that the model is safe, supportive, and accessible for all our clients.
And so evaluation is the important part of the process. The data collection will guide the outcome measurements, continuous improvement efforts, and auditing moving forward. Next slide, please.
After the June symposium, we were inspired to take our Hep C testing further, reaching rural communities. Sorry, guys. speak louder. So after the June symposium, we were inspired to take our hep C testing further, reaching rural communities and mental health units. But first, we set ourselves a challenge: ensure that every single open AODS client had been offered a hep C test. At AODS, our client base primarily consists of OTP clients who generally fall into two main categories. That would be monthly LAI clients, which we have approximately 160, and oral dosing clients, which we have approximately 140. So we rolled up our sleeves and we got to work. Using both CIMA and IEMR, we carefully reviewed each client's record one by one. If no test could be found, we extended our search through OzLab for any past antibody or RNA tests.
Next slide, please. Thank you. So when we identified the gaps in testing, we made it impossible to overlook. We put bright post-it notes on our clients' charts with a clear prompt to offer testing. If they'd never been tested before, we said to offer an antibody test. If they've been tested before and they were positive, we then had to have a point of care test. After testing was completed, or if a client declined, a red dot was placed on their LAI chart. This simple red dot became a powerful signal for every staff member could instantly see whether a client has been tested or if they refused, eliminating confusion and missed opportunities. Next slide.
So with our oral dosing clients, this proved to be a little bit more of a challenge, as clients are only typically seen once every 3 months in person, resulting in fewer opportunities to offer hep C testing. With approximately 140 clients in this cohort, the task ahead was significant. We followed the same careful process used for our LAI clients. To ensure no one was overlooked, we set up targeted reminders in the hep C nurses' diaries to flag when clients have upcoming case manager reviews and medical reviews, so testing could be offered at those key points. To stay on track, we created a dedicated spreadsheet listing all oral dosing clients. This tool allows us to easily monitor and update each client's hep C testing status, ensuring nobody falls through the cracks.
So from day one, our AODS team were fully committed to asking clients at every visit if they were willing to be tested. It quickly became part of our routine, as an everyday question that opened the doors to important conversations about hep C. Even our reception board played a part. This board displayed information regarding hep C testing, ensuring the topic was visible for all clients walking through the door.
Oh, I know the burning question on everyone's lips. Has our hard work paid off? So since June 2025, our team's efforts have translated into real outcomes. So we have tested 67 clients. 25 of them were antibody tests, which we had 2 positives. 46 were point of care tests, and with that we had 2 positive for hep C. So of the 2, one has cleared hep C naturally, which is awesome, and the other one has an appointment booked in next week to commence on hep C treatment.
So the impact so far, since February 2024, our efforts have yielded significant results. So we've tested 250 clients. We've done 56 antibody tests with 2 positive. We've done 194 point of care tests. We've had 38 people positive for hep C. Of that, 18 have commenced treatment and 18 have received SVR. But we've also lost some people, lost them to follow-up. Our clients that are classed as lost to follow-up typically include ones that have returned to prison, disengaged from AODS, relocated outside of our catchment, or been referred to other services. Thanks to Amanda at the Hep C Hub and Chris, Linda, Jackie and Laura from the West Moreton BBV team, who can often reconnect care with incarcerated clients. This collaboration allows us to update our hep C spreadsheet and reclassify previously lost clients to having treatment completed, improving continuity of care and data accuracy.
At Ipswich AODS, we're very fortunate to have Jeanette from Hepatitis Queensland. So she visits us monthly to support our hep C and liver clinic. She provides us with fibre scanning, a vital tool for assessing liver health and guiding treatment decisions. Her involvement adds significant value to the care we offer to all our clients at AODS.
Okay, so This case study highlights a journey of one of our AOD's clients. So the client profile is a 57-year-old male. He has a long history of IV drug use. He's currently on Buvidal 96. His partner is also an IV drug user. He has 2 children aged 18 and 16 and first contracted Hep C back in the 90s. Some of the challenges and barriers that we faced is that he has been sharing equipment with his partner who also has Hep C. There's low motivation, financial hardship due to job loss, ongoing substance use, poor attendance with AOD's appointments, and had interferon treatment in the past but never followed up. He did not want to be retested for Hep C due to his past challenges. Some barriers that were overcome was that he allowed us to test him for Hep C after 7 months of conversations. He tested positive and his partner had also cleared Hep C with treatment. However, he was still unemployed and unable to pay for treatment. We advised that the fee had been covered by a third-party provider and still he didn't want to start treatment. However, the breakthrough came during a candid conversation when the client recalled yelling at his daughter for using his razor, realising that he may be putting them at risk of contracting Hep C. This was the moment of personal insight that became the catalyst for change. After this, the client went to the pharmacy, collected his medication, completed treatment, and achieved SVR. He now feels relieved that he's no longer putting his children at risk.
So our key takeaways: no client miss, test everyone. Simple systems, reminders posted, red dots, simple tracking tools make Hep C testing consistent. Teamwork drives success. So from all the clinical staff, pharmacists, they play a very important role. We would just like to say a very, very big thank you to all the staff and AODs for their incredible support they give to Lisa and myself, because that truly makes a massive difference in what we do. And also a massive thank you to our team leader, Sue, because without her support, we wouldn't be able to do any of this.
Yeah.
Thank you.
Thank you.
Thank you so much for your presentation. That was amazing. I can see now we've got a question for you on the chat box, and this is open to everyone. If you would like to join, and if you've got any questions for Lisa and Grace based on their presentation, on their case study, on the amazing work that they've been doing, please, this is your time to shine and ask them a question. And before you pop them onto the chat box, we've got a question from Kylie. Where did you get your funding for your HCV nurses?
Oh, sorry, we should have put a caveat in that.
Yeah.
We're, Lisa and myself, are case managers and AODs. Hep C is our portfolio, so we just do this as added to a job that we already do. So yeah,
our portfolio that we do within our AOD service.
Yeah.
Very good. Does that answer your question, Kylie?
A little bit. I'm just wondering, did they take you out of did they refill your roles in AODs as a case manager?
No, we still case manager for all client load of people.
Oh, you are.
Yeah, we're still case managers. Hep C is our portfolio, so most of the nurses in AODs have a certain portfolio. Ours is Hep C, and which we've obviously put ourselves forward for because that's what we enjoy doing. But yeah, we do that on top of our regular case management.
So do you have any dedicated Hep C nurses? Or
we
that they
consider ourselves dedicated Hep C nurse. However, yes, we don't do it full time, but we
okay.
Prioritize it.
Thank you.
No worries.
Amazing. Well, we actually have quite a few questions coming through. What I'll do is pass on to Kim before we actually go through all these questions, because I feel like this is a very productive discussion and we can just jump in as a big group at the end of this webinar to go through all the questions. Does that sound like a good plan to everyone?
Yeah.
Wonderful. Okay, just so that we don't miss any bits and pieces of the presentations, and I'm sure we would also be happy to send out the responses to those questions after this webinar. But what I would love to do now is to bring on board Kim Rayner. Are you with us, Kim?
I am. Can you see me?
Lovely. Yes, we can see you. We can hear you.
Can't see myself. So that's good.
Would you like to take control, or should I keep scrolling and you tell me when to go next?
I think probably if you keep scrolling, Fabi, because I haven't got control now. I can't see anything yet. Now I can.
No problem at all. I will mute myself and the stage is yours.
Thank you. So thanks for this opportunity to speak. That was a great presentation too. So thank you to Lisa and Grace. I was asked as Lisa and Grace were to talk about our model or our case study really from a plan, do, act study sort of framework. I haven't gone into all the specifics of our model, so I'm really happy to do that afterwards. I will cover up some of the numbers and who we've treated and what the outcomes have been. But I've sort of just used this presentation to talk about what we did at the beginning in terms of looking at the quality improvement sort of response to get this work going from a Hep C perspective. Thank you. Baby, I might keep moving on. Thank you. I'd like to acknowledge and pay respect to our traditional custodians, the Turrbal and Yagara people, the Yagara people and the elders both past and present on whose land we walk, work and live today here in Brisbane, which is where I am. Thanks, Abby. That's all good. It's just disclosures. Happy to go to the next. So before I sort of discuss what we did from a quality improvement perspective, I was just going to talk about some of the drivers around why we needed to do something. So for those who don't know Micah Projects, we're a not-for-profit organisation here in Brisbane. We've been operating for 30 years. It was established out of the St Mary's community, actually. It's a non-denominational organisation, but that's where it began, trying to respond actively in the community to people experiencing homelessness, largely all across and along the Brisbane River, which is what we're now seeing again in terms of rough sleeping. So that's how it began, was how do we respond to people experiencing homelessness and significant disadvantage. The other key group and piece of work that Mike has set up very early on was responding to people who were experiencing homelessness, mental illness and substance use, but who had been in institutional care as children and abused in institutional care and were now experiencing significant homelessness. So Forgotten Australians, which is now Lotus Place, began, and they were the two areas of service that started Micah off, responding very much to localised community need in Brisbane. Now, 30 years on, we deliver support to 27,000 people a year. There's about 400 staff. The teams that we have are homelessness services that run 7 days a week. We run the Brisbane Domestic Violence Service, family services, which are increasing. So we're trying to support young mothers, increase family services support. A lot more people are experiencing homelessness who are families, so there's a lot of work in that space. Aged care, mental health, and we have a social enterprise arm, along with all the broader advocacy and policy work that we do. From a clinical perspective, I can see Kylie just asked a question. He used to be one of our nurses. We now have 25 nurses, not FTE. That's just 25 nurses across homelessness. DV, we've now got the kombucha women's service up there. There's 2 nurse practitioners now up there. But largely we have support and advocacy workers. And then we have a number of GPs down at our clinic. So that's kind of the context of Micah. What we noticed and why we needed to do something more constructively was we collect information and data. It's called the Vulnerability Index Survey. It's not to survey people to have data. It's meant to actually prioritise our response to individuals based on their health needs, their homelessness history and their vulnerabilities. And it came from a tool developed in the US several years ago that we brought out that was identifying people's morbidity and mortality risk. And I'll get to the mortality risk component in a minute, which sort of drove this work as well. When we looked at that data, which was 3 or 4 years ago, we had a prevalence rate just among Micah Projects participants of 18% of people had self-reported or said they had hepatitis C. When we looked at some of the national data sets, so we are part of the Australia's Advance to Zero with regards to homelessness, 21% of people reported that they had hepatitis C in 2021. Now, they may have been treated and cleared it. They had a history of hepatitis C. Internationally, when you look at hepatitis C and homelessness data, it's high. There's a various range depending on how people are collecting it, but it's high. So for us, we wanted to really have a focused approach in this space of homelessness. We also knew that many of the people we're supporting have histories, past histories or current histories of IV drug use. previous imprisonment. And the other big group for us and for myself, looking at the early data, was really actively targeting people with severe and persistent mental illness who just seemed to not be getting treated at all. And there was also a view that it's too hard. It's all too hard. The other challenge at the beginning was, given the service and what we deliver, it's very crisis response, crisis driven, it's complex work. Hep C just kept falling down. It's not that people weren't committed, we had to kind of raise it up to get going. The other challenge is what I've said, people weren't being treated. That's the target population, which I've sort of touched on. So that became the focus of our Hep C program or response. In terms of staffing, there really wasn't a lot of staffing. It was kind of me advocating. I got allocated a day or two on top of my other work. And I had some support from Quinn and others to sort of get going. And I think I was fortunate that I was working in an organisation where our remit is to respond to the people that I've, been discussing, and to actually advocate for a better outcome. Thanks, Fabi. So way back in late 2021, we'd already done a lot of training, the GPs and myself at that time in 2021. Everything else was sort of bubbling up and taking over. I was doing a lot of work clinically in terms of complexity and disability and mental health. And again, it kind of needed a bit of a focused response. So probably mid-22, we probably started to actively get more involved and do a lot more work. And part of that driver, even though we were already doing the work, was the National Point of Care study that we're a part of, which was excellent because we were able to then take that equipment and do a lot more testing from an outreach perspective, going to where people are at, which is what we do at MICA. The whole model is outreach based. I don't really see anyone in a clinic, or if I'm seeing them in a clinic, it's in some sort of clinical room somewhere else. A lot of it is home visiting or crisis and comm street based work. So what we needed to do at that point, there was a lot of advocacy, and to be honest, it's probably what has already been described. There's a lot of internal advocacy. With data, you have power to advocate and to sort of request a different response. We had to start small. The ASHM training was really critical, and that's obviously people here participating today. But I remember back then learning a lot about how do you sort of case find, case identification, how do you set up a system, start small. And so I learned some really good sort of tools and ways to sort of address it. And also people were really encouraging. So I guess for those who are new to this is talk to your colleagues. There was lots of different people I spoke to. We had Quinn coming out originally doing their point of care testing at the clinic and a couple other sites, and kind of upskilling and building capacity, which was really great. And I really appreciated that at the time, plus our colleagues within the hospitals and across a number of resources which are listed here. You need a project champion, and I can see from the last presentation there's two awesome project champions there. You need one or two people to kind of keep staying focused on it, and I'll talk about that in terms of barriers later on. I developed a project plan, which is what again has been discussed here today, and made a bit of a resource request. Haven't got the resources that I would like. If I had to describe a model on what we could do, we could definitely expand and extend our work. But we're still getting some excellent outcomes. So we got a few resources, which was some time for myself, some admin when we initially started, when we ran the outreach clinics, and that became some protected time just to look at Hep C. The approach more broadly was two-pronged in terms of who was I targeting in terms of services at MICA, and I was targeting our homeless team. So I wasn't going to every single team across MICA. I was focused on homelessness and people with significant complexity. So they were being supported or accessing or moving through our homeless teams and then back into our inclusive health and wellbeing hub. And that hub is integrated with MICA projects. At that time, I think it was just 2 GPs part-time, myself. It's now grown. We have 5 GPs part-time. We're up to probably, I have 3 NPs that are completing their training at the end of the year, and a lot of allied health specialists there. So that sort of shifted as well. But the focus originally was really working with those GPs and then working with the teams across MICA. And the other big piece that we did, and I'm just sort of broadly stating all these sort of aspects or activities, is education and awareness campaign across the whole organisation. For me, I'm educating people who are not clinical. They're excellent support and advocacy workers. They are delivering complex work. it's difficult. And so again, I was trying to create another mechanism to deliver this health education to them so that they were aware of it. We developed lots of little tools that they could use to sort of take out there that would allow them to talk about substance use, harm reduction, Hep C testing and treatment in a really positive way, and to always sort of seize that opportunity, but also to highlight to me who are the people we need to start following up. Thank you. So these were the aims of our PDSA cycle. So I'm trying to sort of match things back to that cycle for everybody. So what were our aims originally? Identify all people and patients with the diagnosis or who self-reported Hep C who have not been treated at the Inclusive Health and Wellness Hub. So that was the first key strategy, is pulling data and information and talking to key clinical staff. And then also across our homeless and housing teams with a focus on homeless, formerly homeless and mental illness. The IV drug use and previous imprisonment, we were pulling all that as well. So all of those data points were being pulled to identify people. We identified people and patients with risk factors, which I've just mentioned. We then implemented follow-up strategies with the GPs, nursing and outreach teams to engage people in education, testing and treatment. So we were quite targeted. It was actually lists of names of people. So the next step within the homeless teams was, do you know these people? Are they still in the team? Are they being supported? This was the information they gave. There was lots of other health information I was trying to talk about at the same time. You know, have they been tested? Have they been linked to a GP? What's occurring? So there's a lot of partnership work and discussion and trying to then get focused names and people we would respond to. Equally within the clinic, it was using our best practice software system, which is what we use there, and trying to pull out people that were at risk or had those risk factors or had identified Hep C. And I'll talk about the challenges to that a bit later, but that's quite critical. There was a lot of names not coming up on that list. So that's your other thing to be thinking about as you start. If you know certain people and you're not seeing them, you need to question the software. You need to go back and redo that data analysis. And then you need to be talking to as many clinicians doing this work about anyone else who's on their radar. I noticed in the previous talk they have very clear sort of ways of getting people to do the testing, which is excellent. I'm needing to often follow that up, but equally the doctors can be doing that testing as well. So we've been pushing that and that's been occurring. And then one of the biggest things was to implement the point of care program and the nurse practitioner outreach clinics across crisis column, hotels, motels and boarding houses, public space, to increase access to testing, treatment and cure, and further case identification. So I guess all of this is about who are the people that are being missed, who are not being followed up, who have a history of Hep C or have risk factors for Hep C and no one's sort of been undertaking that testing, or if they have and they're positive, they haven't been treated. So that was sort of the focus. So case finding in a number of ways and then out testing to case find as well. Thanks, Fabi. So again, this is just a snapshot from the beginning, which is what do we plan? And I talked about that. We did an audit on all of the VI data. It's now called ARVIT, but it's the vulnerability index data. And we pulled lists of people and teams against self-report and risk factors. So there's a lot of data and names and people. But once you have a name, you know who somebody is, you can do a lot with that. You can start working with teams. And Inclusive Health, I spoke earlier, we did a lot of searches, generation of lists for recall and proactive follow-up. And then the point of care, which I talked about, there was lots of planning, who we're going to target. And again, we were trying to go for where we had solid partnerships, but also where we felt that there was not really a great response occurring at all. We made sure it was tied to one of our broader health responses as well. So it wasn't all just about Hep C. And we wanted to be going where we knew there was active drug use and where people not engage well at all in primary health care, if at all, and all respond individually to anything, any individual and agency was wanting us to follow up with. When I first started, a lot of my work and a lot of the treatment effort was with the Inclusive Health group, because there was a lot of people untreated and then the teams of everyone was untreated. So the focus was really someone who's diagnosed that has not been treated. Then we moved on for more of that testing as well. Thank you, Fabi. So in the do, which is, you know, what ideas do you want to action? And we've heard about those in this previous presentation. Everyone will have some ideas now. You're probably already doing them. So for me, I've got lots of ideas that I'm about to implement again in a new cycle. But at the beginning, we generated those lists, and I made sure everyone was aware of it. I talked about the numbers. I talked about those numbers with leadership, with key teams, and the fact that people were untreated and what that meant. And I spoke actively to the doctors regularly. We had meetings with each team leader to discuss lists and check if that person is still with them, which I mentioned earlier, but this is under your do. What are we going to do? And set actions. So we have 2 software systems. We have a client record system that MICA teams use, and then we have best practice that we use as clinicians, which poses challenges. So we had to action into both of those systems. Some people were not known to inclusive health, but they're being supported by MICA and seen by another GP, or most probably not seen at all in primary healthcare. So we had to work across 2 systems. And then a worker, if they were known to a team and they had a worker, they were entered into that database list as well. We had discussions with the practice manager and GPs. I've spoken about that. And then really for me, the list came through. It was just following up. A lot of phone calls. The GPs might have said, are you happy for Kim to give you a call? So I would be doing a lot of calls. I might have gone out with teams, with the outreach teams. If people weren't answering the phone, didn't have a phone, there was a lot of public space. There was just a lot of active follow-up of the initial group to actually try and address the people we knew from this information had Hep C. So before we went off and started doing massive amounts of testing, we were pretty focused. What else do we do? That checklist card that I spoke about for participants, which is sort of here. Posters, lots of big banners. You know, we just really kind of pushed it, a lot of harm reduction messaging, lots and lots of positive material that you can get from everywhere, making sure that that was sort of front and center. And then I made sure everyone had the ASHM decision-making in Hep C tool. There's been some great resources as well, which I've loved from Hepatitis Queensland. I'm going to put that up. There's a new one that's just come out. I just made sure that all the clinicians at the health centre and across even our workers and stuff, wherever I could, there was sort of tools or prompts sitting around. So that were practical as well. And they've been effective. Thanks, Fabi. In terms of studying, you know, what's worked and what worked initially, because again, I'm using the initial sort of setup as this case study. So you definitely need a patient register, which we've talked about here, and a program database. You need to commit time to update that. We currently have 2. We have REDCap, which is off the national database, and then I have an overall one because not everyone's coming through point of care. And then I have subset lists in that, and that's been quite a bit of work. And I'm reviewing and looking at that at all times, and it's got key people that can update that at different points. You have to kind of do it on a regular basis. So we have data going in if we do a big clinic, and then there's a review every fortnight. And then, sorry, I can see that. Thanks, Fabi. I've got that. Working list documents are there. And then I think I've talked about, you know, we've collected data on testing numbers, positive cases, treatment uptake, the population profile. I want to make sure we're actually targeting the people we've focused on. And then the cure rates and completion rates, which people are aware of. We collect all of that data. And then also feedback from participants, patients, staff, and partners. And then under that ACT component, which is the change working? We've built in a reflective practice cycle. We have review discussions with key stakeholders. There's always problem solving going on at an individual level and across the program so that we can get the best treatment outcomes we can for individuals who need additional support. And we talk about ongoing risks and ongoing advocacy. That's continual in terms of trying to get sustainability. In terms of, you know, where are we up to now? I don't know if I'm on to the next slide, Fabi, there. Yeah, I'll get to that in a minute. In terms of how many people have we seen for hepatitis C, since mid-22, it's 507 people have been tested and screened. Of that group, and that's not just point of care, it's non-point of care, 107 were RNA positive. 83 people, and this is when I was reporting this end of June, had completed pre-treatment workup. We're up to about 80 people now who've completed treatment. And that's with resources that have been 1 to 2 days of nursing and try and leverage whatever I can. I now have a nurse who worked for 6 months, 4 days a week, Caroline, who's been funded through donations to keep going so that we can keep the momentum going. And in that cohort of people that we've responded to, at the end of 2024, 78% of those people had schizophrenia and they were completing treatment with a lot of support, high rates of intellectual disability as well. And at June 25, when I look at the cohort we've treated, that severe and persistent mental illness rate sits at around 58, 59%. And that homelessness history is still actively there because, again, we're trying to stay focused in that space. In terms of challenges and barriers, look, I think I've touched on it, resourcing this work. But having said that, and I did learn that at the beginning, you can start small and you can do a lot with not a lot. And we should be doing that. If we're working in the areas that we're working in, we should be responding. So that's pretty much been the approach. We can chip away at this and be persistent and keep working hard, get some runs on the board, share that information across the organisation and keep driving that change. Some of the other challenges have probably been 2 record systems and software systems. You just have to work with that. You have to get good at coding and extracting data. This isn't a challenge or a barrier. You just have to make sure you have this in your project plan. Ongoing education and awareness is critical. You have to make sure that harm reduction, harm minimisation is essential, which we all know is critical, but that needs to keep being a focus. We want to prevent reinfections. I think sometimes that can get a bit lost. So again, I'm trying to get everyone to be thinking about that across the organisation. The national study, while that's been a big commitment, it's actually driven a lot of the QI systems and processes that we've done. So there's been a lot of benefits for us as an organisation without significant resourcing. You need to maintain your databases. You need to have lists of people and keep reviewing them and following up and planning what you're going to do if they're not engaged or if you're concerned you can't find them. So we do a lot of going back and finding people that we're struggling to treat. They sit on a know by name list and we just keep coming back, linking into teams. The other big thing that's really critical in this space is to look at the whole person and respond more broadly than Hep C. And I think it's not a challenge or a barrier. It's kind of really strengthen our program. So kind of working where people are at. You just need to have those links to services if you can't deliver that response more broadly. I'm fortunate that I can link into a number of teams and services or respond myself as an MP, but that's been a strength to the model as well. And the other big challenge really is in our space, to finish this off, is I'm asking lots of different teams and workers who have already got competing interests and complexity to make Hep C a focus and bloodborne viruses a focus, and that can get lost. You just got to keep bringing it up. Others do it really well. So again, you've just got to keep working in partnership and supporting people where you can to do that work. I might leave that there if that's okay, because I know there's questions. And sorry, the resources were there on the last page. I think, Fabi, you may talk about those, but there's great resources out there in terms of the PDSA cycle. So I'm drawing people's attention to ASHM, Beyond the Sea Project Guide. Burnett had done lots of work over time. There's broader ASHM training webinars. There's the Institute website. There's your other colleagues. The PDSA cycle is a project planning evaluation cycle. So whatever works for you, it's just making sure that you're continuously running a system response. Yeah. Thanks, Fabi. Thanks, everyone.
Thank you so much, Kim, for such a wonderful presentation. I'm sure many questions will come through. Just being conscious of time and just wanting to address both presentations, because we also had a few questions coming through for both Lisa and Grace. So what I'll do is just follow the sequence on the questions that were sent to Lisa and Grace. Just one more question to be responded online, and all the other questions we'll probably just have to address them separately on a follow-up email. And please put through the chat box if you've got any questions for Kim while we're responding to Marilyn's question, asking if there were any cirrhotic patients during FibroScan and who sees them. Marilyn, are you still on the call with us? Just going through. And Lisa and Grace, would you like to respond to that question, please?
Yeah, so through FibroScan, we have had a couple of clients that we've had to refer to hepatology at the PA.
PA as in?
Oh, sorry. Prince, it's a hospital in Brisbane.
Prince
It's an
Alfred
outpatient.
Hospital.
Princess
Yes.
Alfred Hospital at sorry to all the
In Brisbane,
rules.
yep.
Apologies. Yeah, so we do refer to specialists if we do find those kinds. That's why having Jeanette and doing the fibro scans is such a great resource
Absolutely.
for us.
Perfect. Whilst I'm still waiting to see whether there's any questions coming through for Kim, just a shout out, there is information on the chat box sent by Ashim from Lana. Thank you so much. In terms of more information on the Beyond the Sea project and program. So the link is there and available, and I'm sure we can all just organize the follow-up email. I will be sending that through with all the resources that we receive. If there is no other burning questions, there's just a comment here from Chris. Prisons need a MICA card for discharge pack scheme. As I mentioned, I will collate these questions just because we won't have time to go through all of them here. And I will be sending that through. But in terms of today, what I would like to share with you all is the opportunity to join the Ensure membership. If you're not a member just yet, there is a QR code on the screen where you can learn more about this opportunity and the benefits of being a member of our institution. And if you have any particular questions, the website is also a very good point to start, but we also have an email dedicated to respond to any questions on the membership. We also would like to hear from you in terms of these webinar on a survey basis. There is a QR code on the screen right now. And if you could please help us to assess these webinar, it would be a very valuable resource data for us to add to the evaluation of this program in Queensland. So this is something that we would love and appreciate from you. If you've got time, it probably should only take you about 3 minutes, if not less than that. And this is just one other promotion here for our community of practice that is coming up as a national community of practice. So this will be a 2-year series where we are putting together very knowledgeable and experts on the ground that are working on regional and remote areas. This project is called Regional Reach and Real Impact, which is a community of practice to improve Hep C outcomes for people who use drugs in the regional and remote Australia. So Inshu will lead this community of practice that connects clinicians, peer workers, public health professionals, and people with lived and living experience of drug use to strengthen hepatitis C prevention, testing, treatment, and liver health outcomes. We are guided by a multi-stakeholder steering committee, and we will be delivering a co-designed series of webinars throughout these 2 years, as well as practical knowledge translation activities to drive service innovation, improve access, and support community-informed models of care. If you've got any interest in knowing more, please just check our website, inshu.org, or you can also scan this QR code, which you can engage on a survey specifically for this particular community of practice. Again, if there is any other questions that you may have, you're welcome to send me an email to fabiana.porto@inshu.org. And this takes us to the end of today, and I would really love to thank you all for your time, your dedication, and especially Lisa Ball, Grace, I don't know you, I'm getting there. Apologies, Grace. This was a hard task for me. And Kim Rayner as well. Thank you everyone for joining us today and taking time. We appreciate you all. Please let us know if you've got any other things coming up in terms of questions, and we'll be soon circulating a follow-up email. Thank you, everyone. All right.